Welcome, everyone. Today, we're going to take a deep dive into critical neurological conditions that you're going to encounter in the emergency department and the intensive care unit. Our objectives are comprehensive. I'm with the goal of equipping you guys with the knowledge and skills necessary for both your NCLEX exams and, more importantly, your clinical practice. We'll start by examining the pathophysiology of seizure disorders, understanding what's happening within the brain during a seizure. We'll also then identify some of the causes of seizures, especially in those critical ill patients. And then we're going to differentiate between the different types of seizures and evaluate the pharmacological treatments available, including some key medications you guys need to know. Nursing actions during and after seizures are also important, so we're going to quickly go over those and some of those best practices to ensure patient safety and recovery. We're also going to take a review of the Glasgow-Coma scale. You guys already are aware of those from health assessment and use in previous courses, but we're going to review it. And then we're going to talk about spinal cord injuries and some of the impacts that it can have on patients. So let's begin today with the pathophysiology of seizure disorders. Okay. At its core, a seizure is a sudden surge of electrical activity in the brain. Okay. Imagine the brain's neurons as like a vast network of wires. A seizure is like an electrical storm that disrupts the normal signals from going through those wires. This abnormal activity often results from an imbalance between excitatory neurotransmitters like glutamine and inhibitory ones like GABA. When excitation outweighs inhibition, the neurons within the brain are going to fire uncontrollably, and then that causes seizures. So both genetic and acquired factors play a role in seizures. Some patients have genetic predispositions that affect ion channels or the neurotransmitter receptors within their brain. Some of the acquired factors that patients may have include brain injuries, tumors, infections, or metabolic imbalances. So these seizures can alter neuronal networks over time, potentially leading to more frequent or severe seizures. This is a phenomenon known as kindling, okay? So understanding this pathophysiology is super important because it underpins how we treat and manage the seizures disorders. So like if you've had one seizure before, you're predisposed for more seizures in the future. It doesn't mean you're gonna have one necessarily, but it makes it to where your chances go up. That's it in a nutshell. So, in critically ill patients, seizures are often symptomatic of underlying issues that require immediate attention. Metabolic disturbances like hypoglycemia, which we all know is low blood sugar, or hyponatremia, low sodium, can provoke seizures because the neurons are highly sensitive to changes in the body's chemistry. Okay. Infections of the central nervous system, such as meningitis or encephalitis, those introduce pathogens that can inflame the brain tissue, disrupting the normal function. Traumatic brain injuries can also cause direct damage to neural tissue, which leads to scar formation, and then that becomes a focus for seizure activity. Drug toxicity is another one of those things that can cause seizures. So overdosing on certain medications or even withdrawal from substances, especially alcohol or benzodiazepines, can precipitate seizures. And then last, we're going to talk about hypoxia. So the lack of oxygen and or ischemia, which is lack of the blood flow, deprive the brain of essential nutrients. And that's going to lead to neuronal death, which can then cause potential seizure activity. So as a nurse, you guys need to recognize the causes that enable us to, these causes, and that's going to enable you and everybody else to respond promptly, potentially reversing the underlying issue if that is a possibility, and also preventing further neurological damage. So understanding the types of seizures is essential for effective management. Okay, so this should be a review for you guys. So I'm going to go over it quickly. Generalized seizures involve both hemispheres of the brain from the onset. Okay, the most common is the tonic-clonic seizure, formerly known as grand mal seizures. This is characterized by a loss of consciousness and violent muscle contractions all over the body. Absent seizures or petit mal seizures are brief lapses in awareness, most commonly found in children. These people sometimes think that like the patient is daydreaming or like staring off into nowhere, like they can't hear you, see you for a few seconds, but they're actually neurological events. Focal seizures start in one area of the brain, okay, So a simple focal seizures, those don't affect consciousness and might involve unusual sensations or jerky movements in one part of the body. Complex focal seizures do affect the consciousness, leading to confusion or repetitive movements like hand wringing. Now, status epilepticus is a prolonged seizure that lasts more than 5 minutes or successive seizures without recovery. So it's like one seizure after another, with like a few seconds in between. Status epilepticus is a medical emergency, and that requires immediate intervention to prevent permanent brain damage, because when it goes on for a long period of time, we could be potentially preventing oxygen and perfusion to the brain and other organs. Okay. And then lastly, febrile seizures. Okay. These most oftenly occur in children between like 6 months and 5 years old, and they're triggered by fever. Now, parents will be super alarmed and they will potentially like come in hysterics, and that is completely normal. Expect that. Okay. But these are normally benign and nothing major. But if it's the first seizure, we're going to take it seriously, even if they have a fever. Okay. And we're going to do the full seizure workup. We're going to probably scan their head. We're going to check their electrolytes to make sure there's no imbalances. We're going to look for signs of infection, and we want to find the infection. If we can't find the infection, then we're going to think the infection is in the brain. Okay. But we're not going to immediately go there. We're going to hope it's like, an ear infection or a UTI or something like that first. We're going to hope that that's the cause. So first seizure in anybody, they're going to get the full multi-million-dollar workup. That's slightly a joke, but anyways, we're going to do a full workup so we can identify what's causing them. But if you've had a febrile seizure in the past and you have another one, there's really nothing to do other than give you Tylenol and send you home. I'm just letting you know. Parents don't like that, but that's what happens. Okay. So you guys need to be able to differentiate these types of seizures, okay? Because that's going to guide us in what we do and how we educate our patients. So your role during a seizure, okay? So if you see a seizure happening, what do you do? So during the seizure, the number one priority is, airway, but also safety. So you're going to clear the area to prevent injury, because right away, airway is not going to be an issue. So the initial thing, somebody starts having a seizure, we're going to promote safety, okay? We're going to clear the area, prevent injury. Do not restrain the patient or insert anything into their mouth, okay? That's old school practice. It's a myth, okay? You are going to position them on their side if it's possible to do so, to maintain that open airway and prevent aspiration, okay? A lot of times secretions build up. Patients might even foam at the mouth. And so if you place them on their side, they won't aspirate, and then the fluids and liquids can hopefully like fall outside of their mouth, okay? You are also going to time the seizure. It's so important. Look at your watch, look at the clock immediately as soon as the seizure starts, and note the time, okay? Knowing whether the seizure lasts 30 seconds or if it's over 5 minutes, it's going to make the biggest difference in how you're going to act, okay? So after the seizure, so we're assuming that this is less than 5 minutes, but no matter what, after the seizure, patients are also often in what is called a post-ictal state, okay? This is where the patient just looks super like drowsy. They're confused. It's like they just woke up after like the longest nap of their life. They might, like I said, they might be confused. They're fatigued. And a lot of times they have a headache. Okay. You're going to assess their vital signs, level of consciousness, and you're going to look for any injuries that they might have gotten during the seizure. Okay. You're also going to provide reassurance as they regain awareness, reorienting them to the situation, what happened. Okay. Because remember, they might be super scared. Okay. Especially if it's their first time. You're also going to document everything, right? You're going to document the duration, the time it started, the time it ended, what you observed from the patient. What did the movement start all over? Did they start on one side of the body and then go to everything else? Like what happened? Okay. You're also going to document if you notice any triggers that happened right before the seizure occurred. Okay. And then also the patient's response afterwards. And prepare for that post-ictal care, which you're going to, you might need to give them some supplemental oxygen. You might need to suction them if they're having difficulty clearing those secretions after they have had the seizure. Okay. Now, if the seizure does not stop, we're going to talk about that in a minute. But right here this is what to do during the typical seizure and the seizure that stops within those 5 minutes. Okay. Okay, pharmacological treatment of seizures. Okay, so what meds do we give? Okay, the big one is anti-epileptic anti-epileptic drugs, okay, such as gabapentin, carbamazepine, phenobarbital, phenytoin, valproic acid, okay. These are the medications that we give, and what they do is they work by suppressing the abnormal neuronal firing in the brain, which essentially is preventing the seizures. So they're basically depressing the ability to for your neurons to fire rapidly. I want you to think about, if I'm preventing the brain neurons from rapidly firing, what is that going to do to all the neurons in my body, or my reaction to things, or my ability for my brain to think fast? Okay, it affects all that stuff, okay? So each drug has a unique mechanism of action, but the common goal is just basically the same. It's to stabilize the neuronal membranes that decrease the excitability of the firing, okay? Treatment is highly individualized. There is no like one size fits all for what medication is given to patients. And we take many considerations into play when we do this, like the type of seizure, how old the patient is, if they have other comorbidities, potential other drug interactions that may happen and occur, okay, but also what caused the seizure to begin with, okay. So if it's because they're detoxing off of alcohol, they're probably going to give them a benzo. Benzos, remember, synthetic alcohol, so we're going to titrate them off of the alcohol that they're drinking themselves we're going to give them man-made alcohol through benzos, and we're going to titrate it down until their body has a chance to adjust to it, okay. So the goals of therapy are straightforward: effectively controlling the seizures while minimizing side effects. Okay, it's, like I said, delicate balance, and frequent monitoring is crucial to adjust the dosage and ensure optimal outcomes. This is often, so we will do this in inpatient, but this is often outpatient on figuring out the right med and everything like that to get them to prevent seizures. Now, emergently, we're going to talk about this in a minute, we're going to give benzos. Like if they're actively having a seizure that doesn't stop, we're going to give a benzo. And that's the more common thing in the ER. And then when they go upstairs, we will switch them to one of these other meds. And we're going to go on to those here now. Okay, so gabapentin. Okay, this is commonly used for partial seizures and neuropathic pain. Okay, a lot of people are on gabapentin because they have nerve pain, a lot of times due to like diabetes and stuff, or they've done damage to their nerve endings. And so now they have random messages being sent to their brain that they're in pain for something. And so we give gabapentin a lot for that, but it can be used for seizures as well. Okay, starting dose, typically 300 milligrams a day. You don't have to remember that, guys. Just remember like the indication, the route, those kind of things. I'm just kind of going over it just so you understand, but you don't have to memorize this stuff. It's the monitor before, evaluate, that stuff, the method. That's really where I want you to remember, okay? But this is an oral medication. Okay, so this is, like I said, it's often given outpatient and following up. This is not, I mean, you will have patients on this in the hospital, especially if they've been on it for a while and they're coming into the hospital as part of their med rec. But so you need to understand it. If you suddenly stop gabapentin after a long time, you can have seizures. So remember that too, okay? So the mechanism of action, okay, so what it does is it works by modulating the activity of GABA, which is one of those inhibitory transmitters, okay? So it's going to modulate it. So, and then what that does is it reduces the excitability of the neurons. So it keeps them from basically spazzing, okay? So common side effects includes dizziness, fatigue, peripheral edema. Patients might also feel a bit drowsy or unsteady. So you got to be aware of safety precautions with patients on this med, especially when they are initiating and first starting the therapy. If they've been on it a long time, it's probably not an issue, but you still need to ask the patient and assess them. So goals of the therapy, super straightforward. It's effective control of seizures while minimizing side effects, okay? Again, delicate balance and frequent monitoring. They're probably going to come in every few weeks in the initial dosaging, and then we can spread that out over months and then years or whatever, depending on if they're having seizure activity or not. So med method for gabapentin, what are you going to do before you give it? Okay, you're going to assess their renal function because it's excreted through the kidneys. If they're an ESRD patient and don't produce urine, probably not giving it. Okay, you're also going to check for history of depression and mood disorders because the medication can sometimes exacerbate those conditions. Doesn't mean we're not going to give it, but we're going to do extra education and precautions on it, okay? We're also going to evaluate the effectiveness after we give it. So we're going to track the reduction in seizure frequency. We're going to be asking the patient to let us know, like, has this, like I said, it's a lot of times long-term, like it's not like a quick thing. Detect reactions. So what we're going to be doing is we're going to be monitoring for those mood changes. We're going to be looking for signs of increased depression and or suicidal thoughts. Also signs of hypersensitivity like a rash or difficulty breathing. Obviously, we're going to stop if that's the case. Okay, no reversal agent. So anyways, that's gabapentin. So carbamazepine. So this is what we use for tonic, clonic, and partial seizures. Initial dose, 200 milligrams twice daily. Again, this is oral, kind of like gabapentin. What this does is it inhibits the sodium channels, which can decrease neuronal firing. Same thing, keeps the neurons from firing quickly, okay? Common side effects, nausea, dizziness, severe, but they're not common, could be what's called blood dyscrasis. And what it is it causes aplastic anemia. And I'm probably pronouncing that wrong because you guys know that I don't pronounce things the best, okay? And agranulocytosis. So we got to monitor blood counts. Okay. So the med method, before we give it, we want to make sure that we get a CBC and liver function test, make sure everything's normal. And also, so we have a baseline. Okay. Because this also might cause bone marrow suppression and hepatotoxicity. Like that would be liver toxicity. So if they've ever had a bone marrow suppression, we probably will not be giving this. Okay. So how do we know it works? Decrease in seizures and severity, right? Pretty easy. So this is one that you're going to need to look out for the skin because it can potentially cause Stevens-Johnson syndrome, okay? Which that is a medical emergency. There's no reversal agent for this sucker. So we want to educate our patient to be looking out for those signs of like the skin rashes and report it immediately if they see it pops up, okay? So next is phenobarbital. And what I think is hilarious about phenobarbital, I have to tell you my quick story, is when you do MedRex on patients, a lot of times, like, they'll be like, I take a little white pill, and they don't remember the names of meds. But sometimes the names that they remember are not the same as the actual real name. So one time we had a patient that came in and we're like, what meds are you on? And she kept saying peanut butter balls. And we're like, is that a street name for a street drug? Like, she's like, no, my doctor gives it to me. And she was just straight faced. I mean, seriously, she could be peanut butter balls. I was like, peanut butter balls? Yeah, we figured it. We're like, what does that use to treat? She's like, I get the seizures. And I was like, you get the seizures? And I was like, do you mean phenobarbital? And she goes, yeah, that might be it. Yeah, it was phenobarbital, but she called it peanut butter balls. And so every time I see phenobarbital, I always have to think about peanut butter balls. Sorry, I just think it's funny. I think it's cute, but it's funny. Okay, anyways, so what is phenobarbital? It is one of those like classic seizure meds that nurses know about. It's one of the oldest meds that is effective for most seizure types, okay, including absent seizures. The dosage can range all over the place depending on how big, how much, how often it needs to be given, all that kind of stuff. There's various ranges, okay? It can be given orally, or it can be given IV, or it can be given IM, okay? So we do use this in the acute care setting, okay? So phenobarbital enhances the GABA activity, which if we enhance the GABA activity, that's going to increase the neuronal inhibition. So when we inhibit something, we stop it. So we're increasing the stoppage of the neurons firing, if that makes sense. Okay, so side effects include sedation, possible respiratory depression, especially with those higher doses, or if we combine it with other CNS depressants. Okay, so that is definitely on there. And this is one of those that has a risk of dependency. Okay. So, with long-term use. So we have to be careful on that. Okay. So before we give it, we're going to assess that respiratory status, and we're going to also evaluate liver and kidney functions because the drug is metabolized in the liver, but excreted through the kidneys. So we want to make sure that they're working okay so that we don't develop toxicity levels, right? So how do we know it's working? How do we know it's effective? We're evaluating the effectiveness. We're going to observe a decrease in seizure activity. Pretty simple. It's kind of like the others, right? So what am I going to look out for the oh no things? Okay. CNS depression, excessive drowsiness, confusion, like excessive, like where they can't maintain their airway. That's not the goal. Okay. So in cases where somebody overdoses on this, so symptoms like nystagmus, which is like the involuntary eye movements, ataxia, which is the loss of coordination, those might occur in those patients. Okay, so Again, no reversal agent, so we're going to just be doing supportive care and symptomatic management in that until the body is able to metabolize and excrete it. So phenytoin, okay, so this one is widely used for tonic-clonic and partial seizures, okay? The dosage, like I said, so 300, 400, it's divided doses in the day. It can be given orally or IV. Phenytoin works by stabilizing the neurons and reduces that repetitive firing, very similar mechanism of action to others. Common side effects. So gingival hyperplasia. So when taken over time, it can cause the overgrowth of gum tissue. Not sure I've ever seen that, but apparently it can do that. Nystagmus and skin rash. So because of its narrow therapeutic index, we've got to check for serum levels to avoid the toxicity. So before we give this med, what are we going to check to make sure it's safe to give? Liver functions, okay? Dental hygiene, discussing dental hygiene before you give it, I guess, whatever. Liver functions. So how do we know it's working? Reduce frequency and severity of the seizures. Okay, so what are we going to be looking for? Okay, after we give it, what are we going to be checking, right? We're going to be regularly monitoring serum phenytoin levels to ensure that they're within that therapeutic range, okay? Signs of toxicity, these are important. Ataxia, confusion, nystagmus. Okay, so there's no reversal agent. So if the toxicity occurs, we're going to adjust the dose, not stop. These meds, you don't ever stop seizure meds. I think that's very important to do. We don't ever stop them suddenly, okay? We need to gradually go off because your brain and the neuron excitability is something that is super sensitive to the things that are affecting it, like the electrolytes, but also these meds. You stop them immediately, you're going to make your patient have seizures, okay? We don't want to do that. So we're going to reduce it if it's toxic, okay? Now, if it's like super overdose, like somebody deliberately took a whole bunch of pills and stuff, we can do dialysis, but it's going to be supportive care, okay? Massive supportive care, probably intubating them and that kind of thing. But again, we're never going to go cold turkey and stop because that's going to cause seizures itself. Okay, I hope that makes sense. We may switch to another med that's like a brother, sister, cousin chemically, depending on what it was, but we don't ever want to stop cold turkey seizure meds. Okay, so now valproic acid. This is effective against multiple seizure types, okay, including like multiple seizures, like tonic-clonic, partial seizures, and focal seizures. So this is often given, also used for patients in bipolar disorder management. So remember that, okay? So this should be some crossover with your psych behavioral health class as well. Okay, so we can give this oral or IV, and it works by increasing the GABA levels in the brain, which will enhance the ability to inhibit. Okay, so it's going to cause decreased excitability. So some of those big side effects include hepatotoxicity, so it's going to affect the liver, and possible pancreatitis, which can be severe. It's also teratogen. It's a teratogen. That's easier to say. Okay, so it's contraindicated in pregnancy because it's going to cross the placenta and it can cause harm to a fetus. So we don't want to give this into a pregnant lady. So before we give it, what are we going to check for? A pregnancy test. We want to make sure if it's somebody of childbearing, if it's a woman of childbearing age, we want to give them a pregnancy test before we start this, okay? We also are going to check the liver function, right? Right? Correct. Okay. So how do we know it works? Because decreased in seizure frequency and improved mood stability if we're using it for a bipolar. Okay, so what are some of those big reactions that we're going to be looking for? We're going to detect the reactions. We're going to be monitoring for signs of pancreatitis. So that's going to be like severe abdominal pain, nausea, vomiting. We're also going to be doing, while the patient's taking this, we're going to be doing regular liver function tests to make sure that we don't have hepatotoxicity. Again, no antidote for these, so we're going to be supportive, okay? But if it's severe side effects, we're going to stop it and switch it to another med, okay? So monitoring serum levels and medications, okay? This is super important in some of these medications. It ensures that those drug concentrations remain within that therapeutic range, and a lot of these have narrow therapeutic ranges, okay? So we have to be careful. Okay, we don't want to cause toxicity, but we want to have a therapeutic effect, right? So medications like phenytoin, Carbamazepine and valproic acid require regular monitoring due to those narrow therapeutic windows. Okay, as nurses, you're responsible for scheduling and obtaining those lab draws, especially in the outpatient setting. Make sure that you're on time. If you're in the hospital setting, they're going to have like lab draws at a certain time. You want to make sure that you and or lab is getting those pulled at the right time so they can truly check what the expected levels should be in the body at that time based off of the time of administration. Okay, so it's so important that you're documenting everything as accurately as possible, even the given like the time of the med admin. Okay, because we need to be drawing levels as indicated. Okay. And then again, if you get a lab value back that it's closing in and or on the toxic level, you should be notifying the healthcare provider so we can adjust those dosages. Okay. So now let's kind of switch gears and talk about a little bit more about some neuro assessments. This is again a review, the Glasgow Coma Scale. Look at the picture on the screen. You're going to see the 3 different areas, and you give a point to each, and then the score can be between 3, a minimum of 3, a maximum of 15. If it's 8 or less, we intubate. Remember, that's a comatose client. So hopefully it's above 8. But anyways, this is the scoring, and you can pause, look at it. It's pretty self-explanatory. This is a very common assessment that we do on all patients that come through the ER, especially if they're a trauma patient or something neurologically or even psychology, like any psych patients that come through. Okay, so the significance of the GCS findings. Okay, so a decreased GCS score is a big red flag. Okay, it may indicate a worsening neurological function due to factors like that increased ICP that we've already talked about, bleeding in the brain, swelling in the brain. Okay, so for example, if a patient who was previously scoring a 15 suddenly drops to a 12, that's a big deal. Okay, they might become less responsive, have impaired airway protection, or be at risk for hypoxia. Immediate implications include the need for airway management, perhaps even as aggressive as intubation to secure that airway, okay? It necessitates urgent medical interventions like administering medications to reduce the ICP or ordering a CAT scan to figure out what's going on. As nurses, you guys need to be performing the GCS assessments frequently, especially if the patient is at risk of neurological issues, okay? Any decrease should be promptly reported to the healthcare provider and be prepared to assist with interventions, whether that's setting up for imaging or medications. So, pupillary changes. So these are, again, a big part of the neurological assessment and the status of your patients. They can indicate changes in intracranial pressure and brainstem function. Dilated pupils may suggest an increase in ICP or herniation. Okay, big dilated pupils. Constricted pupils, we sometimes call them pinpoint pupils, could be due to damage in the brain, but also a lot of times opioids. So like if you come in and say you're not on meds and you have these teeny tiny little pinpoint pupils, I'm like, liar. Anyways, let's get a drug screening on you. Okay, anyways, unequal pupils, okay, may indicate localized brain injury, okay? Now, if you see, like the picture on the screen, unequal pupils inside, especially if your patient's awake, but if their family member's there, ask them, is this normal? It can be normal. Like it could be somebody's baseline. It's probably not. It's not that common, but always ask, is this normal? If you see like a difference in them. And if it's not, you better be notifying people, okay? Big deal, okay? So we can just shine the light and check the pupils. You know, we're checking to make sure they're even. We're checking to make sure they're reactive to light, Perla, if y'all remember that. But they also have fancy little pupillary, I forgot what they're called. They look little measurement things you can hold up, and it's giving more of an objective assessment of the pupils. It measures, it's a pupillometer or something. I forgot what it's called. And I've only ever seen them, they don't give them to ER nurses, but I've seen them in the ICU, especially neuro ICU. And I like them because, again, it's more objective assessment. So if you have the fancy tools, I say use them. Okay, so we're kind of going over something we already went over in the previous lecture, but Cushing's triad. So you need to be looking at vital signs. If you even think for a hot second there's something neurologically going on and an impairment in your patient. So we're going to also look for temperature changes, especially hyperthermia, okay? That might result from a hypothalamic injury, okay? So if the temperature is erratic and goes up, okay, wait, what's going on? This is not normal. Especially if there's no signs of infection and they just had a head trauma, okay, like that's not normal. So bradycardia, it's often associated with an increase in ICP, right? Because what it's doing is the ICP is actually putting pressure on the vagus nerve, which is going to decrease the bradycardia and the brainstem. Hypertension with that widening pulse pressure that we already talked about in the previous lecture, that is part of the Cushing's triad, indicating significant increased ICP. Okay, so you're going to be continuously monitoring all of the vital signs in your patient, okay, and addressing those underlying causes so that we can prevent the deterioration and negative outcomes. So myasthenia gravis, what is this? Okay, so this, we're kind of switching gears again to a new topic. So this is an autoimmune disorder where antibodies in the patient's body are attacking acetylcholine receptors and at the neuromuscular junction, okay? So this is your body is thinking that acetylcholine is foreign and the receptors are foreign and I'm going to attack and destroy them. And this causes lots of issues. Okay, so muscle weakness is the big hallmark thing. And it's muscle weakness that worsens with activity, but it improves with rest. Okay, that's other common symptoms: ptosis, which is the drooping of the eyelid, double vision, and difficulty swallowing. So this disease can progress unpredictably. Okay, so you can have like nothing happen over long periods and all of a sudden exacerbation. Okay, so remission, exacerbation, remission, exacerbation. A severe complication is called a myasthenic crisis. And when a patient is in a myasthenic crisis, this involves respiratory muscle weakness. Okay, so we can understand why this would be a crisis because we're probably going to have to mechanically support the respiratory and ventilatory status of our patients during this exacerbation. Okay, so just know that that's what that is. Now, Guillain-Barré, hopefully you've heard about this before, and hopefully this is a review, but this is another autoimmune disorder. This is often triggered by a viral or a bacterial infection before Guillain-Barré shows its ugly face. So the immune system during this after a viral or bacterial infection, the immune system is, into an overdrive. It's been, working its thing to clear up the infection, right? But then what happens in Guillain-Barré is that it mistakenly attacks the myelin sheath of peripheral nerves, thinking that it's part of bad things that shouldn't be there. Okay, so when it's attacking the myelin sheath, this leads to muscle weakness, okay? But it starts typically in the peripheral nerves. So you're going to first start to see the weakness in the periphery, right? So we call this ascending or starting from the bottom and going to the top weakness, okay? Ascending muscle weakness starting in the legs and moving upward. So patients are going to exhibit areflexia, which I could say it's the absence of reflexes, and may experience respiratory compromise, okay, if the paralysis reaches the muscles involved in breathing. Okay, and so the progression of this disease, Guillain-Barré progresses rapidly, but many patients recover fully with appropriate treatment. Okay, so some of those treatments include IV immunoglobulin therapy. Okay, so the difference between Guillain-Barré and myasthenia gravis is kind of more of a fluctuating thing, and it's more over time. Guillain-Barré is typically fast. Okay, the other thing is Guillain-Barré, like I said, is the ascending. Okay, so ascending means it moves upwards. So it starts in the toes, moves upwards. If you've ever heard of botulism, side story, that's descending paralysis, and that's why it's so dangerous in babies, is because it starts at the top and it moves down. So it's going to affect the lungs before you ever even notice that the arms and legs have weakness. Okay, so the baby can't breathe before the arms and the legs. Whereas an adult that gets botulism with the descending paralysis, they would notice that there was issues and be able to hopefully seek treatment before, but a baby can't talk, right? So we would be assessing them and it would affect their lungs before we'd ever notice the weakness. Okay, so that's botulism. But Guillain-Barré is the opposite. It's the ascending. So it starts from the bottom and it moves upwards. So they would start having issues and weaknesses in their fingers and toes and legs and arms before it moves up to the respiratory system. Okay. It can affect the respiratory system, but hopefully it doesn't. Okay. But sometimes people with Guillain-Barré, they get put into the hospital so that we can monitor for this. And if it does reach the respiratory system, like I said, we might have to intervene possibly with ventilatory support, but hopefully they recover completely. And we've got some things like the immunoglobulin and the plasmapheresis is another thing that we can do to treat it. Okay. So nursing care for both of them. We're going to monitor the respiratory status because that's the thing that we're worried the most about, right? So we want to monitor for that because the risk for respiratory muscle involvement and paralysis. So we're going to assess the swallowing ability because we also want to prevent aspiration. Okay, that's more typically more of an issue with the myasthenia gravis than the Guillain-Barré, but it can affect both. Okay, so we're also going to provide mobility support through physical therapy, assistive devices. Safety is a big, big, big issue with these patients. We don't want them tripping and falling because of their issues neurologically with their motor movements. Okay, we're also going to be administering the medications as ordered, and we're going to be educating the patients about their conditions, the treatment plan, the signs of complications, and the emotional support. They can both be very scary for patients and very worrisome. And so just constant education, family and friends and patients, providing them that emotional support holistically is definitely needed. Okay, so now switching gears again. So now we're going to talk about brain death. Okay, so confirming brain death involves rigorous testing. We don't just do subjective neuro assessments and say, oh, the brain's no longer functioning. Okay, we have touched on this in the organ donation and other previous lectures, but I want to go over this again so we make sure that we get some of these concepts clarified for you guys. So we will do clinical assessments, and those are going to include verifying a deep coma is present, so with a known cause. So we're ensuring that there's not a reversible condition that's contributing to the state. Okay, we want to figure out what is causing this. It may be obvious, but it may require a lot of testing. So this is not something that can just happen in an hour. Okay, like this takes time. The absence, so we're going to be also assessing for the absence of brain stem reflexes. So those would be pupillary response, a gag reflex, and response to a painful stimulus. Okay. If they have one of those, it delays. Okay. That means there's still some brainstem function. If they do not have all three of those, then we can move on to the next thing. We're then going to be testing the apnea test to assess for the absence of spontaneous breathing when carbon dioxide levels rise. So your body would naturally, so if we're ventilating these patients on their own, we're kind of maintaining that equilibrium. Okay. So when they do this apnea test, they're going to allow the carbon dioxide levels to rise, because if your body has neurological function, when it detects the carbon dioxide levels rising, it will cause the spontaneous breathing. It will cause an increase in breathing, okay, to blow that off. So if that doesn't happen, then they have apnea and they fail the test, but then that is an indicator that would lead towards the confirmation of brain death, okay? So if the clinical assessments are inconclusive, then we're going to also do ancillary tests like an EEG. I guarantee you that we're going to do an EEG on everybody to produce for brain death, especially if they are looking at organ donation. Okay, so EEG is one of those things that they're going to be looking at the electrical activity of the cerebral blood flow and or looking at the cerebral blood flow to look for the brain activity. So the picture I have on the screen is an EEG of a little baby. It's not necessarily that that little baby is confirming brain death, but the EEG is all the little stickers all over the head. There's different time frames for an EEG test. Sometimes just in general, not just for brain death, but EEGs can be done for 20 minutes. They can be done for days at a time. These can be done outpatient homebound. Like you can have a patient set up with an EEG sent home, especially children where we think they're having seizures, but we're not sure, like focal seizures and stuff. You can send them home and then it's recording, a device is recording it over days. But definitely an EEG on there. And so as a nurse, you guys are going to be doing lots of documentation and the timing of these tests, because we need legally and ethically, we need it documented that these things happened. Like the assessments are not just one assessment. Like we have done multiple neuro assessments to, confirm there's no gag reflex, confirm there's no pupillary response, those kind of things, right? And we want to make sure that that goes over so that people can families can fully, healthcare team can fully know the situation and make the best decision possible. So some nursing interventions for a peaceful death. Okay. In caring for patients, at their end of their life. Okay. Our goal is going to shift towards peaceful death. Okay. Pain management is going to become paramount. Okay. We don't want uncontrolled pain because that can cause unnecessary suffering. Okay. So we're going to implement comfort measures. And that can be as simple as positioning the patient, offering extra blankets, or cooling, or whatever the case may be, getting a fan for them, extra pillows, whatever the case may be. It also includes skincare, also creating a peaceful environment, music, lighting, those kind of things. People that are peaceful to the patient, okay? Also, just being present for the patient, providing emotional support, listening to them, offering reassurance, both to the patient and the families, okay? We also want to encourage family involvement according to whatever the patient's wishes are, okay? So that, again, like I said, can provide comfort to the patients, just to have their families present. And this is super, super important. Just think about if it was you or your loved one, okay? But you also need to be mindful of the cultural and spiritual considerations that are individualized per patient, okay? Ask your patient if they have any practices, or if they have any religion, or if they have any needs that you can help assist or facilitate, as they're nearing death. Okay. So just remember that the different beliefs of our patients can influence how they and their families are perceiving the whole death and dying process. So make sure that you don't treat your patient like a number. They're individual. They're individual. They are their own person, and you want to tailor your care to respect their values. Okay, switching gears again. Okay, so now let's talk about spinal cord injury, okay, and the classifications. Okay, so these spinal cord injuries are devastating events, okay? Nobody anticipates having a spinal cord injury the morning that they wake up and then they receive one, okay? These events are going to require precise assessments and the management afterwards, okay? We want to prevent further harm, but it's completely life-changing for these patients and their families. Okay, so the first thing, other than the initial stabilization of these patients, is we want to know the mechanism of injury. Okay, so like, how did the injury occur? So was it flexion or bending forward, hyperextension, bending backward, compression due to like a force from above or below, like they fell and hit their heels and the force went up through their spine, or something like that, or a rotation and twisting of the spine. So the level of injury, or like where the injury occurs. So in the cervical region, the thoracic, lumbar, sacral, that determines the extent of the impairment. Okay. So we want to know where we all will always you're going to always report that the injury is at, say, T2 or C6 or whatever the case may be. So we're going to identify the level of injury. Okay. The higher up the level, especially in the cervical region, can affect more systems, obviously, in the body. And that cervical region is the one that is typically the most devastating. So the higher up, it can affect the respiratory function, heart function, all sorts of stuff like that, while the lower injuries may only affect the lower limbs. Okay. So what we need to do is we need to differentiate between also complete or incomplete injuries. A complete injury means that there's absolutely no function below the level of injury, while incomplete means that there's some function that remains. Okay, it could be one or the other. So there are specific spinal cord syndromes that we need to also discuss. Okay, so there's central cord syndrome. This is when basically, often it's because of a hyperextension injury that affects the upper extremities more than the lower ones. Okay. The Brown-Séquard syndrome is a hemisection. So what that means is it's affecting like one side versus the other. So the spinal cord gets injured and it leads to like a motor loss on the same side as the injury and a sensory loss on the opposite side. It's kind of crazy. It's hard to explain, but it's Brown-Séquard is like hemi. So it's like right versus left kind of thing. So anterior cord syndrome is damage to the front of the spinal cord, and that results in a motor function, loss of motor function and pain and temperature sensation below the level, but it preserves the position and vibration sense within the patient. Now, the posterior cord syndrome, that is more rare. It affects the proprioception. So like your ability to like feel closeness to things and kind of balance kind of stuff. So what that does is, so it affects that, which leads to difficulty walking and coordinating movements below the level of injury. Okay. So you have the central cord syndrome, Brown-Séquard syndrome, posterior cord, and anterior cord. And you need to be able to know the differences and be able to differentiate between those four. Sorry. Okay, so spinal shock versus autonomic dysreflexia. Okay, spinal shock is an immediate response to a spinal cord injury, which is characterized by a loss of all reflexes and activity below the level of injury. So it'll be like flaccid paralysis, absolutely nothing below the level of injury. Okay, so this is, it happens immediately. Now, to say that it is permanent, we don't always know right away. Okay. So just because somebody immediately loses all function doesn't mean that they may not gain it back. There could be swelling, there could be compression, but if it goes away quickly enough, or nerves are really finicky. There's some that are definitely a lot more, I don't know the right word to say. They're more temperamental than others, and there's no ifs, ands, or buts, or like it's hard to tell like who's going to have more persnickety nerves than the next person. Okay, so sometimes like when nerves get irritated, they just completely like, it's like a toddler flopping on the floor and like acting like having a hissy fit, and you're like, really? Versus somebody else that barely gets like touched and they're just like, they're going on their way. I mean, they may get punched and they're just fine, and somebody else, you barely like touch them and they're like flopping on the floor. Nerves are kind of the similar way. So just because something isn't working doesn't mean that you're not going to regain function. But for the most part, and almost a lot of injuries to the spinal cord are going to result in some sort of neurosensory loss. But like I said, we typically wait a few days before we give like full prognosis of like what's going to happen in the future. And there is still hope in the immediate aftermath of an injury, unless it's just super traumatic. Then anyways. Okay. So spinal shock is not necessarily permanent. Okay. But it's just right after an injury, complete loss. A lot of times it is indicative of permanent loss. But like I said, sometimes that goes away. Now, what is autonomic dysreflexia? Okay, this is a big one. You guys need to know what this is. You need to be able to spot it without somebody telling you what it is and know what to do. Okay, what this is it's potentially life-threatening. Okay, if somebody has a spinal cord injury, okay, and they come in with hypertension, bradycardia, pounding headache, those kind of things, you guys need to be like, warning, 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 warning. Okay. Like big deal. Okay. And this is like sudden kind of stuff, because what's happening is there's a exaggerated autonomic response happening in the body to some sort of stimulus, painful or irritating stimulus that is occurring below the level of injury. So if it's below the level of injury, the patient can't feel it. So it doesn't know what's happening. So like, UTIs can cause this, or like a wound on the leg can cause this. There's lots of things that can cause this. Okay. So if somebody has a paralysis, okay, and let's just say like they have their injury is at, say, I don't know, let's just go like T2, T3 or whatever. So, and they get a bladder infection or a bladder distension. It could even just be that their bladder is full, because patients that are paralyzed have to do self-cath. They don't get the sensations of a normal, like functioning body, that their bladder is full and they need to urinate. So their bladder just keeps getting bigger, bigger, bigger. And they don't have the ability to control it, because that's voluntary muscle movements to release the urine from your bladder when you go to the bathroom, right? So these patients self-cath. Well, if they don't self-cath every so often, we put them on a bladder and bowel schedule typically, and so that they just cath themselves every so often to make sure it stays empty. Well, let's just say for some reason they produced more urine than normal, or they weren't able to catheterize themselves because they were out of supplies, or they were like traveling and they just didn't have time, or I don't know what the case may be. The bladder can become distended. Well, they wouldn't know. Okay. And this is painful. Okay. And so the stimulus is going to cause this exaggerated autonomic response. Okay. And then what happens is the whole body basically freaks out. Okay. So it's, you guys need to be able to quickly identify, and what the treatment is remove the triggering stimulus. Okay, so we got to figure out what's going on. Quickly scan the body. Is there any wound? Is there any pain? Is there any injury? I don't know. Okay, let's check the bladder. Let's cath them. We're going to check for infections. We're going to check anything that can be stimulating and causing this pain that's causing this issue. If you do not remove the triggering stimulus or fix it really quickly, it can lead to all sorts of complications, and it can be life-threatening for these patients. Okay, so the nursing management for autonomic dysreflexia is the first thing is identify and remove the trigger. Okay. For spinal shock, you're going to monitor and support the patient as needed, and you're going to try to prevent future injuries. Okay. So nursing and medical management of SCIs. So this is spinal cord injuries, in case you don't realize what an SCI is. Okay. So it's multifaceted here. Okay. The immediate intervention is, again, preventing further injury, stabilizing the spine, using the C-collars, backboards, maintaining the airway, and ensuring the ABCs are in full effect, right? Okay, so we may give some meds like methylprednisolone, which may be administered to reduce the inflammation around the spinal cord. Though it is controversial, so I need to talk about that, and it depends on what facility you work at. So some places don't believe in it, some it's part of their protocol, so there's that. Okay, we also want to prevent complications. So that would be preventing pressure ulcers. Again, that can cause autonomic dysreflexia. Pressure ulcer can. Okay, so we want to make sure we are turning these patients frequently. We need to be educating these families and friends that they need to be sitting on pillows. They need to be preventing, like I said, skin breakdown. We need to be doing the heel pads, putting their heels on pillows, or whatever the case may be. We need to be working with case management if they're newly diagnosed. It's a new injury on social workers getting all these kind of things set up, hospital bed maybe, and at their home. There's so much that's involved in this. Okay. So another complication that might cause it is deep vein thrombosis. Think about it. You're not moving your muscles. We can get clots, right? So we might be putting patients on prophylactic anticoagulants and compression devices again. So reiterating, autonomic dysreflexia is a life-threatening condition that occurs in injuries typically above T6. Okay. It's that exaggerated response of the autonomic nervous system to the stimuli in the body that the patient's unaware of. Like I said, full bladder, bowel, might be an infected foot or toenail. I don't know. It could be a lot of different things. I'm going to reiterate those signs for autonomic dysreflexia. Okay. That includes hypertension, bradycardia, and headache. The immediate action is needed to remove that triggering stimulus and lower the blood pressure. Okay. And then again, you're just going to focus on rehab and emotional support. Spinal cord injuries, they really do have a profound psychological impact on our patients and their families. Okay. They will mourn the life they thought they were going to have, the experiences that they thought they're going to have, because an able-bodied person that's able to use all four limbs and sense things, all of a sudden everything has changed and they don't know what their future holds. They don't know how people are going to react to them. They don't know. There's so much that's unknown. And so this can be very, very emotionally, I mean, just think about if it was you. Just put yourself in their shoes and all the thoughts and worries and concerns and stresses that you might be under. Okay. So keep that in mind when you're caring for these patients. Again, we already kind of talked about this. So, sorry, I jumped the gun on some things. So you can have grief, anger, depression, literally the whole mourning process that people mourn their life, the life that was before there's life before the injury, and there's life after the injury. And it's for not just the patients, families too, especially those dynamics. There's such stress on the caregiver. Of whoever, you love this person. The person is still hopefully there mentally and emotionally, but like their body is the thing that's not the same as before the injury. And so it just puts all sorts of new challenges on everybody. Okay. So big need for patient and family education, specific about their injury, those self-care techniques. You start to have to teach them about the bowel and bladder regimen. You have to teach them about autonomic dysreflexia. You have to teach them about taking care of things, about, how do pressure ulcers occur and how to prevent them. There's so much involved. Okay. There are available resources out there, and there are lots of support groups. And so this is where you want to get social worker involved, case managers involved, and getting resources and support groups and all that kind of stuff. So as a nurse, you guys need to advocate for your patients, but you might also be providing them with counseling and therapeutic communication. So it's being a listening ear sometimes is so therapeutic, right? But then a big part is there's such a big education need for these families and patients. Okay, so specific to that education, okay, they need to understand the nature and extent of the injury. They need to understand the self-care techniques, and you need to be able to teach it to them. They need to be inspecting the skin daily, okay, multiple times a day, to prevent those pressure ulcers, noting that y'all know, that just a little redness is the first sign of it. Don't think it's just, oh, what we need to, like it's not a big deal. Like we need to get the weight off that reddened area, right? These are all the things you're going to be teaching them, everything. The bladder management routines. You're going to be demonstrating the use of assistive devices to promote independence, okay? We might be referring them to, like I said, physical therapy, occupational therapy, all sorts of therapies. This is where hospitals like TIER, Memorial Hermann is great. They have so many resources involved for these patients, and they just have programs set up that follow the patients, and it's great. But if you don't work in a place that is specific for rehab hospital, like that's an expert in this area, you might be needing to be the advocate to reach out to find these support groups and help facilitate that with the patients and the families. Okay. Again, that ongoing emotional support and encouraging them for follow-up care and making sure that they have that established. They know when to follow up, who to contact if there's complications and all that kind of stuff. So now the last thing we're going to talk about is baclofen. So back pain is a big issue. Baclofen is very commonly used to treat muscle spasticity in spinal cord injury patients, but also patients with back pain, chronic back pain. So they even have baclofen pumps. They actually surgically implant the pump with the little, I guess, the catheter into the area where the pain is coming from the spinal cord, and it provides pain relief for, these are chronic back pain patients, but we're going to switch to specifically SCI. Okay. So baclofen acts as a GABA agonist. Okay. So it inhibits the nerve transmission to the spinal cord. So it reduces muscle tone. It can be administered orally or through that intrathecal pump that I talked about that sometimes happens, like severe chronic back pain. So that is an option for SCI patients as well. Dosages vary based on the route. Okay. Some of the common side effects especially if it gets absorbed into central CNS. So drowsiness, dizziness, muscle weakness. Okay. They can affect safety. So you got to monitor the patient, extra education on safety and movement and mobility. Okay. So what do you got to monitor before? We want to assess the degree of muscle spasticity in evaluating the renal function, because this med is excreted through the kidneys. We want to make sure the kidneys are working, obviously. So how do we know it's working? Decrease in muscle tone, improved ability to perform activities of daily living, and increased comfort, less pain. Okay. So what are we going to do to detect reactions and look for? So we're going to observe for signs of the CNS depression, such as excessive drowsiness or confusion. We're going to also monitor for urinary retention, which is a side effect due to the decreased muscle tone in the bladder. Okay, no reversal agent. So we're just going to provide supportive care and notify the healthcare provider immediately if we think that there is too much of it, and provide the supportive care until we decide what to do. And that concludes Module 6B. Don't forget, again, to review the readings and the learning objectives.